Okay, let's go over a few things about complications, and we'll go through this quick. Transfusion reaction. I remember when I was first in the blood bank, this was the thing that gives you nightmares. You cross-match that unit of blood, and then the nursing unit calls and says, this patient's having a reaction, and immediately causes heart pounding. Oh my God, what did I do? And usually it's not, a major ABO compatibility. Uh, Usually it's some other minor situation, or it's something that the nursing staff maybe, if they were watching the patient a little bit better, could have alleviated. So remember, the ones that are really bad, of course, are your hemolytic, febrile transfusion reactions. You can have hemolytic, febrile nonhemolytic, urticarial, anaphylactic, and transfusion-related lung injury. That trolley, that's also relatively new. You can also have some non-immune mediated transfusion reactions that are bacterial contamination. That'll put your patient into a reaction immediately. Physical red blood cell damage, or citrate toxicity, or circulatory overload. In my experience in the blood bank, I have seen a lot of this, and it was mainly from either not inspecting the unit clearly when you gave it out. It is important to look at the unit, make sure it doesn't look funny. Hemolyzed cells look funny. Bacterial contamination can cause hemolysis. Deteriorating red cells, it's even the little bit of plasma that's left in there when you pull the bag out should be relatively clear. If it's not, I'd set that unit aside and pick up another one and go back to it if you're, busy. Even clots, sometimes they don't mix the unit correctly, and you can have big clots forming. All right, now intravascular hemolytic reaction usually involves a clerical error involving the ABO system. And this is what happened recently at Lawnwood that we talked about, that the patient was drawn by, person X, whoever it was, and they had a handful of blood and handed it to the phlebotomist and pointed, it's that guy's over there. And the phlebotomist made the assumption that it was that patient's blood and mislabeled the blood. So this patient was given A blood and he was an O. All right. So the only thing that saved this guy was the fact that he was in renal failure anyways, and they put him on dialysis. So the dialysis kind of covered up the fact that he was given ABO incompatible blood. But let me tell you, if you give somebody ABO incompatible blood, they are gonna have a reaction. And usually it is very quick. Very quick. They start, saying I don't feel well, or they spike a fever. And remember, what happens is you're going to have massive hemolysis. You're going to start to have hemoglobin show up in the urine, so you might get bright red urine, and sometimes even the plasma of the blood that is drawn will look red. Now, if you tested for haptoglobin, what would the haptoglobin be? It will be low, right? Because what is haptoglobin? It's the protein that binds up free hemoglobin. If it's all bound up, haptoglobin is going to be low. Now, extravascular hemolytic transfusion reaction can be due to RhIG, Kell, Kidd, Duffy. And many times what happens is this causes what we call a delayed transfusion reaction. So you can give the unit to the patient, even 1 or 2 units. Sometimes days the patient starts having a reaction. We had a patient one time that had a Diego antibody, very unusual. It took 2 weeks, and the patient came back in, and we were perplexed. But the patient was jaundiced, showing hemolysis, and then, of course, we couldn't even determine the antibody. We knew the patient had some sort of unusual antibody, and it turned out to be, in that particular case, it was a Diego, which I've never seen. Exactly, and you're not going to know that. You're not going to know that. There are many unusual antigens, which you can have a patient that might have one of those low incidence antibodies, and there's just no way to test for it unless for some reason that antibody is high enough that when you pick that unit, you're going to get an incompatibility. But with electronic cross matches and immediate spin, you're not going to see it. And in that case, the patient did fine. The patient didn't have a problem. It was over a period of time they had to just get rid of that blood. But unfortunately, they were given the blood and they hemolyzed a good portion of it. Now, Urticarial. This is one I have experienced firsthand when I actually cross-matched a unit of blood for a patient, and she was in the OR, and the OR called up and said, we're having a transfusion reaction. So I had to go over and actually draw the blood, and this gal had just woke up from surgery, was covered with hives, all over her body, and I looked at her and I said, "What are you allergic to anything?" And she said, "Well, I'm allergic to oranges, grapefruit." She goes, "Anything with citric acid." And I went, "Bingo!" I said, "The unit of blood," I said, the stuff in it has citrate. And let me tell you, she reacted immediately and was covered with hives. So the response, of course, they gave her Benadryl and the anti-allergy stuff, to antihistamines, to get the reaction down. But they gave her the whole unit of blood before noticing that she was having a reaction. Well, you know, if you're doing a surgical procedure and need to give the unit, you might not notice all of a sudden that the patient is breaking out in hives during surgery. All right, your febrile nonhemolytic is one of the most common that is reported. Patient spikes a little fever. They either call the physician and say, "What do we do?" Many times they'll say, give them some sort of medication such as Benadryl or something to lower the fever, reduce the reaction, and continue the reaction. Those kind of people who have this reaction should be given leukoreduced blood. Trolley is something that this kind of came in after I was actively working in the blood bank, but what they're finding is it's antibodies to the HLA or neutrophil antigen, and what happens is you can have patients that will have severe reactions. And what I read a paper about this, and some of the reactions are from the donor was a female who had so many pregnancies, like 4 or 5 pregnancies. And during those pregnancies, she had many HLA antigen or antibodies were much stronger, and then they gave it to a patient that had a reaction. So they were looking at the fact that some of the donors, and I guess they're going to start looking at trolley in a little bit more detail with what kind of donors cause this. But it was an interesting paper of why it occurred. Anaphylactic shock, of course, is always problematic because your patient can die, and usually you're going to see this with only a few mLs of blood. And the classic case is your IgA deficient patient with an anti-IgA. It reacts with any residual plasma in that bag of blood, and then they will have a reaction. So those kind of patients, you want to make sure that you wash. They give washed red cells. So the unit of blood should be saline washed before you give it. So some of the different types, you guys can read through this. Most of the, we already went over those particular ones. Now, one of the first things when you do a transfusion reaction workup, clerical. Make sure the numbers are correct. Make sure all of the was given to the correct patient. Patient has the right unit of right armband, etc. Then you want to immediately redo your ABO and do a direct antiglobulin test to make sure that it is still negative. So you want to do repeat the pre-ABO, RhIG, and DAT, and do post to make sure that they match. All right. And if that patient at Lawnwood had this done, that would have never occurred. They would have seen right away that it did not match. Okay. You can also look for in the urine to see if there's hemoglobin in the urine. Look at the pre-transfusion urine to see if it's clear. Post-transfusion to see if there's positive for blood. Remember, the dipstick will give you positive for hemoglobin. If you have a patient that has hemolysis, they could also be having hemolysis for other reasons, such as sickle cell, thalassemia, or other things. Remember, too, that some of these problems can occur if you heat up a unit. They do use blood warmers that are like a microwave. So I always blame this on nurses. They throw it in there to warm it up and cook it, basically. It comes out brown, and they give it to the patient. Of course, what's going to happen? Patient's going to have a severe reaction. That has been documented. Or frozen. Remember, too, that you're going to have a lot more hemolyzed cells there. Transfusion-related infections we've already talked about. We know that there was a look back. You always want to report something that may be associated with a transfusion. Graft versus host is rare, but it can be lethal, especially to patients undergoing chemotherapy for either leukemia or some other thing. Maybe you have had a bone marrow transplant. What is interesting is we got a patient who had come before she had the bone marrow transplant, and she was like an A. And after the bone marrow transplant, she typed as an O. And of course, we scratched our head because we're like, wait a minute, isn't this the same patient? And we looked back, and she had a bone marrow transplant from somebody who was an O, but it was HLA typed. They gave her the most common. So it's not always the exact same ABO type, and they said over a period of time she will revert back to her normal blood type, but because of the bone marrow transplant for this particular type, and I don't know what she got, a stem cell. Now let's talk about hemolytic disease of the newborn. What is HDN? Erythroblastosis fetalis is the medical term. And what it means is that the baby's red cells are being destroyed by the mother's antibodies. Now, that can occur by mother making your unexpected antibodies, or by mother's anti-A or anti-B. Usually in those O mothers, they make a very potent A, B, which can cross through the placenta, and if the baby is an A or a B, can affect that baby significantly. So right now, what is the most common cause of hemolytic disease of the newborn? Right now? It is an ABO incompatibility. It used to be D. Why is it not D anymore? Antenatal RhOGAM. Not just RhOGAM. Now they are giving RhOGAM before delivery. And remember, when you go through the actual process of birth, what happens during that transition with the actual labor is you get fetal maternal bleed. So that blood then is seeding mom's blood, and she can develop antibodies. So if you're given that beforehand, that antibody can help eat up any of the baby's cells before you can actually develop an antibody. So that is really called passive immunization, because you are giving the mother an antibody that she is not making, but it is passively protecting her from making future antibodies. Now, we know what causes it, and some cause it worse than others. Some Rh negative mothers never develop an anti-D antibody or other antibodies. Way back in my time, my mother was Rh negative, and they told her after the first baby that they had to watch the second one. That's what she told me. That's all they told me, that they had to watch the second one. And she never developed anti-D, so she wasn't going to. I mean, there are people who develop antibodies very easily. Their immune systems are different. But now we give the antenatal RhOGAM to all Rh negative mothers. And remember, what happens is that mom is seeing the baby's red cells as being foreign. So it doesn't matter if it's D, it could also be others such as little e, big C, any of those that could potentially cross the placenta and cause sensitization of the mom's immune system. All right. One of the most common is your ABO, because mom makes a very strong A, B antibody that will attack those baby's red cells. So usually you can see ABO incompatibilities the first time around in new mothers, but you usually don't see anti-D occurring in first mothers, because they must be sensitized by either a blood transfusion or a previous pregnancy. Okay, and then we know future pregnancies are the ones that you have a problem with. Now remember what happens to the baby. Cross over into what we talked about in chemistry. As the baby is in utero, its red cells are being destroyed. So what happens? The bilirubin starts to go up. So now when this infant is born, say in the first hours of delivery, that bilirubin level may be as high as 15. So could this baby have a potential problem of kernicterus? Remember what kernicterus is? Yes. And usually those are the babies then. An ABO is done, an RH, a direct antiglobulin test to determine does this baby have a positive direct Coombs, an elution to see what antibody is on the red cells, and then a possible exchange transfusion. All right, now remember, this is how it works in most facilities. Mom comes in, she's Rh negative, all right? Routinely, the doctor will give antenatal RhOGAM at about, I think it's about 6 months they do it, okay? Doesn't matter if she comes in and says, well, my husband is Rh negative, because if she's Rh negative and the husband's Rh negative, are they going to have an Rh positive baby? How could they? They can't, okay? Unless it's the mailman. But you have to think of what a physician has to think. okay? It is for the protection. It could be the mailman, okay? I mean, you don't know. All you're going to say is the mom is Rh negative. Give her antenatal RhOgam, all right? Now, some of the complications that can occur with hemolytic disease of the newborn can be quite severe. And I have not, well, in this area, our hospitals are pretty small. If you go to a big area like Orlando, you might see this a little bit more commonly, where they are actually transfusing infants and possibly doing some exchange transfusion. Now, if they do an exchange transfusion, how do you cross-match the blood? So you want it to be compatible to the mom. This is when you first go, well, wait a minute, isn't this baby already having a problem with the mom? Yes, so that's what you want to do. So if you have an A baby that has anti-A, B on its red cells, what are you going to transfuse this baby with? O, okay? You want to give it because the mom's O, you're going to give that to the baby. We used to actually take the mom and cross-match the mother to the unit and then give the baby that unit of blood. Now, in that particular instance, you do need whole blood. The unit should be less than 5 days old. You want fresh blood. And how they do it, they pull out, usually have an umbilical catheter. They pull out maybe 50 cc's, discard. They take 50 cc's from the unit and put it into the baby. So what they're doing is actually exchanging over, circulatory over a period of time. The idea is to lower the bilirubin so you don't stain their brain cells and lower the amount of antibody and those incompatible red cells till this child can get over this. All right. Remember, how do we actually diagnose this? We're going to get cord blood. And how do you do cord blood, ABO, and DAT testing? You want to wash it because it has wart and jelly. So you want to wash it a good 6 times to make sure you get all of that out because it can interfere with your direct Coombs. Do an ABO, an RH, and a direct Coombs. Now, if the direct Coombs is positive, that's where then you're going to do an elution. So you would elute off what is on that baby's red cells and do an antibody screen or an full antibody panel to determine what it is. All right, so, and really the treatment has to do with how this baby does. We've had babies that have bilirubins as high as 27, but their direct bili was 17. So what does it say about that? What's happening with this baby? The liver is conjugating the bilirubin. And does direct bilirubin cause a problem in the brain? What is direct bilirubin? It's the water-soluble bilirubin. It is conjugated to the diglucuronide, remember that? And it can be excreted in the urine. So the baby will actually start excreting that, not only in the urine, in the feces, to lower the bilirubin. And I remember the pediatrician said, no, we're not going to do an exchange because the baby is responding on their own. So if they start responding on their own, they do nothing. Now, how do you determine, how do you prevent this? Antenatal RhOgam, and now this comes to how much RhOgam should be given after birth. All right, one of the things that need to be done is if you have a mom who is Rh negative and they suspect of having a large fetal maternal bleed, 1 vial of RhOgam covers 30 milliliters of whole blood. I thought it was 15. For some reason, I'm thinking 15. So you have to calculate, and there is a calculation to use for determining RhOGAM. Remember, what you have to do is you have to do the Klein-Howard-Betke test. So this is different than the fetal maternal rosetting test. They do the rosetting test to see if there are infant cells. Then you have to determine how much. So with the Klein-Howard-Betke, you're going to count them. And what is the Klein-Howard-Betke test based on? Hemoglobin F. Because fetal hemoglobin is much more resistant to alkali. All right? So you can use that, and what you're going to see is the mom cells kind of ghost out, and the baby cells remain dark, right? Because the fetal cells stain light red, and the moms are, yeah, and here you can see in this light picture, this I would say is a fetal cell. You see how they're stained darker because they are resisting the alkali. Then you want to count them, and you want to count them and count per 1,000. So you want to count all the cells, count how many fetal cells you see in 1,000, which will give you a percent. Okay? Then you're going to take that percent and you multiply it by 50, which will give you the number of mLs of fetal blood. So, for instance, if you have 16 fetal cells, let me see if no, there is no examples. So if you have 16 fetal cells per 1,000, that's 1.6%. You take 1.6%, multiply it by 50. That gives you 80 mLs of Rh positive fetal blood. So you're saying you have 80 mLs of blood circulating in mom. 1 unit of RhOGAM covers 30. So divide the 80 by 30. So in this case, you're going to get 2.7 doses. Because the 0.7, you want to then round it up to 3. Okay, if it was below 0.5, you would round it down. So in this case, it would be 3 vials, and because the testing is pretty inaccurate, you add 1 vial. So in this case, you're going to give 4 vials of RhOGAM. Okay? Understand? So remember, always round up and add 1 vial. All right, and this should be transfusions in certain populations. Massive transfusion is defined as 10 units of whole blood. Remember, at this point in time, this patient has no blood of their own. We always had a policy that after 10 units, you didn't need to cross-match anymore because the patient basically had no antibodies left. If they had a screen that was negative, really it just didn't matter. At that point in time, you were supporting them, trying to get them through whatever problem that they had. One of the most common things that we saw in the blood bank was esophageal varices. Have you guys heard of this? This is usually when you have an alcoholic, they drink a lot of alcohol. What it does is it actually burns the esophagus, the area that the esophagus connects to the stomach. It actually disintegrates and separates. When that disintegrates and separates, it causes massive hemorrhage because there's, a very large vessel there. And what happens is the patient will start bleeding into the stomach, vomiting, and or over a period of time, of course, causing it to be GI or come out the other end. These patients can bleed huge amounts of blood. So these are like surgical procedure. You need to get them into the OR immediately because you can pour in your whole refrigerator full of banked blood before you're even trying to get this patient stable. We had a patient one time that was on about 25 or 30 units of blood that was coming out of the refrigerator. We call the blood bank, and the guy in the blood bank's like, you know, I can't give you any more units, because he was like, oh, you're depleting the whole county's blood in this one patient. Are you taking this guy to the OR? Or are you just messing around here giving him blood? And so they finally took him to the OR, and the patient ended up dying anyways. But the thing is, the guy, all of that blood that we were giving him was going right into his stomach, and it was awful. What a terrible thing to have done to you. And really, you've got to have good surgical intervention if you're bleeding that badly, because somebody's got to open you up and stop the bleeding. Because you can give as many units, as many products as you want, it's all going to leak right out. You got to fix the problem. Now remember, you've got to look at, you know, what is going on and what product that you should be given. And it depends on what is the particular reason that you're giving the transfusion. Are you transfusing this patient because of coagulopathy? Are you transfusing them for anemia due to blood loss or anemia of cancer type? So there is a lot of different types, and usually the physician will pick a certain product that he wants. He's not always correct, and sometimes and I wouldn't say you, but over a period of time it might be you having to call the doctor and say, are you sure you want this product? Because this product is used for this reason, and by the lab results I don't see that happening with this patient. Maybe a more appropriate product would be, and then he might say, yes, I want that because, you know, this patient has XYZ, and you say, okay. All right. Now, therapeutic hemopheresis is done to take out certain proteins that might be in that patient's blood to try to reduce whatever's there, such as in multiple myeloma, where you have huge amounts of antibody that may be interfering with a lot of biological processes. You're only going to do this if you think the patient might get better. I know they try this stuff with things like Guillain-Barré syndrome to try to reduce the antibody and the antibody-antigen complexes being formed. And I know that sometimes the patients do get better, and that's the whole reasoning, to give the patient a hold so that they can start getting better instead of having to put them on a ventilator with Guillain-Barré, for instance. With oncology, some of you are going to go out and work at some of the facilities that do a lot of cancer research, cancer therapies. Those patients are treated much differently than a routine transfusion, such as what we do down at Sebastian. I mean, most of that is support therapy to either patients under chemotherapy or your older patients whose bone marrows are not making the cells like they used to, all right, or surgical reasons. And you guys can go through this and review the transfusion support and what should be possibly given, or just review. Okay. Now there are some alternatives to transfusion. What I heard recently is they are coming out with fake blood. Have you guys heard this? It is a fluoridated compound because fluoride can carry oxygen as well and actually cause it to be exchanged in the lungs. So they were doing some research on it, and I think some of it is available. They're also coming up with the blood that will now be scrubbed. They actually tan the red cell with tannic acid. And when you think about all of the things that we do is because there are antigens on the cell surface. So when we give a patient an A type of blood, we are giving them that because there's antigen on the surface, correct? So if you tan it, you take the tannic acid, strip off all of these antigens, that makes that red cell a universal donor, meaning that I don't have to cross-match blood anymore. I'm just going to go, take it out of the refrigerator and go, here, give that to that patient. This is a universal donor. I guarantee you in our lifetime this will happen. This will happen because it's going to make every unit of blood be used more sufficiently, and you won't have antibodies being formed because you're actually giving the patient ABO-related antigens, RH antigens, or unusual things that are related to what is on the red cell. That will completely change everything. Now remember, things with donor selection, meaning if you are actually donating, I don't think it's going to change that very much, but it will change the way we do things in the blood bank, because we won't be doing ABO on those units of blood anymore. Okay, so the way we process and hand out blood in a clinic or hospital is going to be totally different. Okay, and last but not least, let's talk about the manufacturing practices. You must remember that blood bank is under the guidelines of the FDA, because anything that is put inside a human being is overseen by the FDA. All right. Now, record keeping and all of the document control, all of this is overseen by the FDA. So one of the, many of the things that come into play with this is you must have a qualified person with training and education that goes along with doing this testing. You should have a facility that is designed and a work environment that is designed for safety. What do you notice about most blood banks in a laboratory? They have 4 walls, meaning that they are not like right out here in the middle of the lab. And why is that? Because you must concentrate on what you're doing. Right, there you go. You got to think you're on an island and the ocean is surrounding you. Now, lawnwood, though, they can do that because lawnwood, it's on one side. That's all that's over there. But anybody can walk in and out of a blood bank. And it is, Sebastian, it's like a little hall closet. It's like a little room. But Indian River made 4 walls, but you can still walk in and out. No problem. Yeah, it is separated, and that's how you can do that. But if you look at Martin's a segregated room that does nothing but blood bank, and all blood banks are like that. If you go to St. Mary's, I know they have, between hematology and blood bank, there's a door. So it is segregated. So you have to remember, it is done for the fact that you need to concentrate. Now, and I'm going to tell you this, that if you have one of these chatty Cathy type of co-workers that likes to come in there and sit because they're all done doing chemistry, but you're doing blood bank and you need to concentrate, you need to tell them, you know what, let me get this done and then we can take a break, okay? because sometimes people chatting, you lose concentration, and they should know better. They should know better than coming in and chatting, while you're doing this. Yeah. All right. Now, record keeping is very significant in the blood bank. You have to use permanent ink. You can't erase things. You have to cross them out. And we're going to talk about the labeling in a minute. We're going to go through this label because the new ICD-9 coding label, which every facility should be wanting using a computer barcode, which most of you have experience with and are using now, is done. So you can see what is acceptable and what is not here. You have to write your initials. Don't erase it. Just cross it out and make sure that you know what happened. I know what happens occasionally at Sebastian is when a unit of blood is being brought back, say it wasn't given, first thing you do is you take the temperature. I throw it right on the temperature thing before anything happens. I look at the time. If it's more than 30 minutes, I go, sorry, wasted. I put it in the wasted area. But say it's 25 minutes. I said, okay, let's see what the temperature is. Now, if that gal took it and went like this as she's walking down the hall because she's warming it up for her patient, when she gets it back to the lab, if it is more than 10 degrees, wasted, throw it away. Okay? But if she kept it in the little bag or whatever, however she transported it, it might be okay. All right? You must write then in the record, this is where I cross it out. I write returned, time, date, and temperature. Okay? And if it was wasted, I write on their unit wasted. And I make sure I write on the unit wasted. Not good, take out of inventory so that you know. Now, AABB is the American Association of Blood Banks. It is not AAB, in which you'll be getting your certificate. That's the American Association of Bioanalysts. But the AAB oversees blood banking, policy, and procedures. Okay? So, many times, labs will look at what is the AABB protocol for this particular policy and procedure and change accordingly. The minimum time that you should keep a record is 5 years. What record should you be kept indefinitely? So if the patient is alive, when you think about it, has antibodies or has been given units of blood, those records should be kept indefinitely, either on microfiche or in a card system. Many labs are going to computer now, where the patients, they can just look in the patient file, computerize, and the patient comes up. All right? But things that are paper records, for instance, that are basic cross-matching, minimum of 5 years. Now, job qualifications, personnel. Remember, the thing is training and education. And we're going to go back over some of these about CLIA and what CLIA says. CLIA says that you should have at least a high school diploma and be trained. Okay? Now, certain high-level categories, such as blood banking, okay, many of the criteria for that is minimum of an AS degree with training. Now, remember, it is not the same throughout the whole United States. You might have people who are on the job trained, do not have a lick of college, but they have the training. Okay? And that is the big thing. If they have the training, they may not have all of the education. And like I said, we're going to go back over some of the CLIA requirements and go over what is moderate complex, high complex. Okay? Blood banking is considered high complex. If you go to California as a technician, you are not allowed to do blood banking. That was one of the criteria when they put licensing in for technicians. Technicians do no blood bank. They consider that high-level testing. You have to have a minimum of a bachelor's degree. That's with California. If you must have a bachelor's degree in order to get a license in the state of California as a technologist. If you have an AS degree, you get a MLT license. So there are two levels of licensure, not unlike what Florida should be. But see, Florida should be like that, but because of the laws and rules, remember that, remember doing the whole career thing, the laws and rules of the state you have to follow. All right, now one of the things, hold that for 1 second, is error management, the root cause analysis. Remember, in the blood bank, what kind of error do you want to have in the blood bank? Zero. It better be zero. And there better be checks and balances in place. This is what I'm having you guys do online, and I'll repeat this again because people are like, what do we need that thing for? When you go on to Media Lab, you're going to do prevention of medical errors, which covers root cause analysis and looking at medical errors, how to prevent them. So that is one of the things you have to do, and you have to print out your certificate, and that's part of the things that they're talking about here, okay, is analyzing what can cause an error. All right. Remember too, and we talked about design of the blood bank, calibration of the instrumentation. Remember that centrifuge that you're using to do ABOs must be calibrated so that you know you are correctly centrifuging. If you're using gel, remember there is a correct QC amount of centrifugation, incubation, for all of that. All right, so remember that, you know, one of the things, last but not least, is proficiency testing. All labs should be in a proficiency testing program, and all technologists that are working in the blood bank should be part of that proficiency program. Okay, now remember, I already went over FDA. The AABB is a voluntary accrediting agency, but most labs are also part of the AABB system. All right. Now, here's where we're going to look at the labels because this is something new. The ISO, they basically have looked at the standard of practice for blood banking to actually look over the regulatory and the safety effects, or how to improve that with blood banking. And that comes with the labeling, and we're going to look at that label in a minute. Okay. Storage and transport, we're going to also look at that on this next sheet. I think it's best that you write things in. It kind of helps you to remember that particular area. Okay?